Carsten Palme. He will be speaking on extent of thyroidectomy, utility of guidelines and scoring systems in preoperative prediction of thyroidectomy. Sir, over to you, sir.
Can everybody see my screen?
Yes, sir.
Great. Dear Dr. Singh, thank you very much for this honor. And to my colleague and good friend Akshay Gudbachi and also Dr. Vishal Raya, thank you very much. I think this is such a wonderful initiative and you really should be congratulated for this amazing amount of work you've done in putting in all these webinars. I've been charged with the topic today of talking on the extent of surgery in well-differentiated thyroid cancer, and I really would like at the outset to let everybody know that this is a personal perspective. Treatment of thyroid cancer is actually can be quite controversial on many aspects, and what I'm going to present today is by no means comprehensive, and it's very much a personal opinion. Now let me so thyroid cancer, just to go back to the epidemiology, we've really seen a massive increase in number of cases. Certainly in Australia, we've seen a doubling or tripling of cases, but fortunately the death rate hasn't changed. And really the question beggars, why is this happening? Are we picking up all these incidental micropapillary carcinomas that we shouldn't really be picking up? And when we look at the epidemiology, you know, probably about 10 to 30% of the world's population has a little bit of cancer in their thyroid. And given the increased use of high resolution ultrasounds, we're certainly picking up a lot of these cancers. But fortunately, the death rate, and certainly here you can see the CS database hasn't really changed. And these results have certainly been mirrored in our units in Australia. I mean, how do these patients present? And as I said, the vast majority of patients with well-differentiated thyroid cancer are essentially asymptomatic. Somebody notices a little lump in the neck, you know, a relative or a doctor, or an ultrasound is performed for some throat discomfort or Globus type of symptoms. And the feared invasion of the upper air digestive tract, although in some units approaching about 20%, which I think is mainly due to those high volume centers with specialty, is actually pretty uncommon. Neck disease in terms of lymph node presentation can occur in up to a third to a fifth of patient, but again, generally it's pretty uncommon. However, what is common is micrometastatic disease. And we know from these wonderful studies done by the Japanese that all levels covering 2, 3, 4, and 5, including 6, have very high rates of micrometastatic disease. So if you look at the central compartment, you know, that rate is well above 50%. But we must not forget level 4 and level 3, where the incidence approaches 40 to 50%. And certainly that really drives the way we do neck dissection, where we're encompassing those levels in patients that present with clinically relevant disease. Distant disease does happen and is possibly present in 5% of people, up to 5%. But again, I think that's probably a bit of an overestimation in terms of what we see in clinical reality. Oops. When you look at the staging system, there has been a significant change. And really one of the biggest changes that has occurred is that the age cutoff, where before it was 45 years of age, has been lifted to 55. Minor extrathyroidal extension has really been eliminated as a factor that upstages patients. And certainly even gross extrathyroidal extension, although initially be seen to be a stage 4 or T4 category, has now been downgraded. And if you look at the staging, if you're less than 55 years old and a woman, you can only really become a stage 2 if you have distant metastatic disease. And if you look at greater than stage 5, you really need to have significant extrathyroidal spread invading anything else other than the strap muscles to be upstaged to T3 or T4. What are the treatment options for well-differentiated thyroid cancer? Well, they are observation or active surveillance. One can perform surgery. Radioactive iodine certainly is used in an adjuvant setting, and thyroxine suppression is liberally used. External beam radiation is used in those people with residual macroscopic disease or patients who are inoperable for other reasons. And then there are certainly a number of trial drugs that have been looked at. The aims of treatment, intuitively, it's really to improve survival. But, you know, in patients who are younger than 55, that's a pretty difficult ask because a lot of those patients do extremely well. So I think improving survival is probably reserved for those patients with cancer who are older than 55. And one of the more significant things is actually to improve the disease-free interval and reduce the related morbidity. Treatment allows us, or surgery allows us, to accurately stage patients and allocate risk stratification. And importantly, one of the big aims is really to reduce treatment-related morbidity and avoid over-treatment, and importantly, avoid and prevent unnecessary, ineffective, and expensive therapies. When we look at the extent of surgery, we need to consider the thyroid clearly. We need to consider the neck lymph nodes and the upper air digestive tract. Clearly, surgery can be used at distant site, but this is a little bit beyond the talk today. So what do the decisions upon what we do rest on? Well, foremost, they relate to patient factors. And importantly, are we dealing with low-risk young patients? Are we dealing with high-risk male patients with a history of ionizing radiation and a significant family history? Are we dealing with patients who are cooperative and who are going to return for follow-up? It rests on tumor factors. Clearly depends on the type of pathology, the size of the tumor, what's going on in terms of the invasion, and what's the stage of disease. Is there a need for adjuvant radiation? And what is the possibility of surveilling these people? And importantly, physician factors really depend on the philosophy, not only of the surgeon, but also the endocrinologist and the institution upon which the patient is being treated. It certainly rests on volume of treatment, and we certainly know from other disease groups that the more you treat something, the better you're going to become and getting better outcomes. Memorial Sloan Kettering some years ago divided patients into low, intermediate, and high risk groups. And I think that's been actually a very beneficial and very valuable way of looking at patients. And again, a low risk patient would be a young female, less than 55, with a small tumor and no risk factors. And a high risk patient would be one male, older, with a larger tumor. And certainly, depending on where those patients fit, you are either going to upscale or downscale treatment. Importantly, Mike Tuttle has really taught us that in terms of factors, there are actually static factors, factors that we know that we can't change, such as patient factors, the tumor factors, but then there are also dynamic factors. Certainly, how does a patient respond to initial treatment that drives how aggressive we may be? And then importantly, there are a whole host of factors which we know is going to increase the risk of structural disease recurrence, which again will divide those patients into low, intermediate, and high risk patients. But overall, the decision depends on a risk-benefit analysis that will always need to be made in the, with the benefit to the patient. You know, we need to really balance, do we need to do a total thyroidectomy, central neck dissection, radioactive iodine for a 5mm incidental micropapillary carcinoma? And the answer is clearly no. So the decision always needs to be done with the patient clearly at front and center. When you look at the evidence, and this is a great slide that kindly was given to me by Ashok Shaha, you know, the literature is replete with evidence on pretty well every approach for thyroid cancer. And the numbers of papers that are being published are staggering. So it is a very difficult field to get your head around. But one of the things that has really helped us has been a consensus of experts, which has really led to the American Thyroid Association guidelines of 2015. And importantly, personal opinion and experience goes into deciding how these patients are ultimately treated. I think it's much easier to start where there isn't any great dilemma, and that is those tumors that are greater than 4 centimeters, as you can see in that chap there. These are lesions that are clearly at high risk of recurrence and persistent disease. These are clearly lesions that are at high risk of extrathyroidal extension and significantly impairing disease-specific outcome. And in those patients, generally, the treatment, without doubt, would be a total thyroidectomy and aggressive removal of any lymph node disease and removal of extrathyroidal spread to facilitate a clear removal of the tumor, radioactive iodine, and certainly to improve surveillance with both ultrasound and thyroglobulin. Certainly in those tumors that are less than 4 centimeters that do show significant extrathyroidal spread or clinical neck or distant disease, again, I think there is little doubt and debate that total thyroidectomy would be the treatment of choice. When you get to tumors between 1 to 4 centimeters, this is really where the controversy starts. And this is where the risk stratification by memorial into low, intermediate, and high has really helped us in deciding which patients are well treated with simple hemi or thyroidectomy or lobectomy, or those patients that need a total thyroidectomy up front. And when you look at some of the data, there is actually very little difference between a huge amount of people that have been treated with these low-risk tumors if you're looking between hemithyroidectomy and total thyroidectomy. Certainly the survival, there isn't any great difference. However, possibly those patients who've been treated with lobectomy up front probably have a higher rate of recurrence. However, they've all been able to be salvaged, which really has led to no significant difference in disease-specific survival. So again, ultimately, how you decide to treat this patient depends on the patient. Importantly, depends on the state of the other side when you're having a solitary nodule on one side, and importantly, our institutional and physician philosophies. And really, the recommendations from the American Thyroid Association are pretty clear that hemithyroidectomy in those patients with tumors less than 4 centimeters can be safely performed in those low to intermediate risk patients. I think a caveat is that you have a very compliant patient, a patient that understands the challenges and certainly agrees to follow up. Because as I said, the local regional recurrence rate is probably a little bit higher in those groups, however, has no effect on survival and surgical salvage is possible. As we get smaller and smaller, the controversy increases. And here we are in those patients who, by definition, present with micropapillary carcinomas, on those cancers that are less than 1 centimeter in diameter. And as I said, if you look at autopsy studies around the world, the incidence is probably about 10 to 30% in the normal population. The treatments that have been offered to those patients has been anything from hemithyroidectomy, observation, to total thyroidectomy. And again, we need to consider patient factors, tumor factors, and institutional factors before working out what is the most appropriate patient for our patient who's sitting in front of us. If you're looking at those patients that have undergone surgery, and most of those patients would have undergone hemithyroidectomy potentially, they have very good outcomes. Mortality is low, local regional recurrence is low, and the development of distant metastatic disease is also very low. Active observation is a concept that really was started off by Professor Ito in a wonderful publication looking at patients undergoing a close observation. And he has clearly shown that tumor progression, and when you look at his original paper, that tumor progression was actually just a few millimeters, was actually pretty low, less than 5% at 5 years and less than 10% at 10 years. Unsurprisingly, in a way, younger patients were more likely to progress than older patients. And the question is, was that a factor of watching these people for a longer time, or are there some indigenous factors? Is a little unclear. Regional failure overall was also low at less than 5%, and really there wasn't a whole lot of difference or issue in terms of survival. So when you look at what is the most appropriate way of treating these patients, as I said again, we need to put together all the factors as outlined, develop a risk-benefit analysis, and the options really are a period of active surveillance, surgery, and my initial recommendation would be to favor a conservative procedure. I don't really think there is a role for elective neck dissection, and base further treatment on what you found at surgery and those static and dynamic factors that Professor Tuttle has let us know. And I think you're going to do very well and treat your patients and avoid any unnecessary risks. What's the question in terms of completion thyroidectomy? And we might be in this situation if our initial plan was to perform total thyroidectomy, and we may have had a concern regarding the recurrent laryngeal nerve. So if you thought that at the initial operation that a total thyroidectomy was indicated, you probably should continue to do that. But if you initially felt that the patient might get away with a hemithyroidectomy, if you look at the factors there on the right-hand side, and if you have clinical lymph nodes, or if you have lymph nodes involved, it's a potentially multifocal tumor, and then there's an extrathyroidal spread or some other adverse features, there may be an indication, or, you know, and often is an indication to complete and remove the other side. And certainly in those patients where you would feel that the addition of radioactive iodine and better surveillance with ultrasound and thyroglobulin would be beneficial, should all undergo completion thyroidectomy. If we're looking at neck nodes, and I'm really just going to summarize this fairly quickly, clearly if you have lateral neck nodes that are involved, you should perform surgery to remove those. However, if there are no clinical nodes, it is controversial. We do know from the a series from Japan that micrometastases are incredibly common. However, the significance is significantly put in question. We do know that lymph nodes do have an impact on recurrence and survival, but probably only in older patients, male patients, those patients with large primaries, a significant amount of lymph nodes or greater numbers of lymph nodes, and certainly if there is any distant metastatic disease. Because if you look at some of our young patients and if you look at some data from Queensland, really there wasn't a whole lot of difference between those patients with clinical nodes or no clinical nodes. So in summary, if you have a lymph node disease, they should be removed, and you should perform a compartment-based dissections covering level 2 to 5B. And Deepak commented on this earlier. One of the nodes and group of nodes that are often missed are those within the carotid sheath and within an area called the carotid triangle, which basically is bounded by the scalenus anterior, the scalenus anterior here, and the longest colli muscle medially. The carotid artery goes through it, and the vertebral artery is the posterior extent, and the base is really the subclavian artery. And often these are the areas where lymph node disease might be missed, and you really need to be quite thorough in dissecting that area. The central neck is incredibly controversial. One of the first things you need to understand is the boundaries of the central neck, which extends from the hyoid bone right down to the suprasternal notch, and from one carotid artery to the other. One must not forget level 7, the superior mediastinum, which extends from the suprasternal notch to the innominate artery, and is really an extension of the central neck. There is clearly an appetite for elective neck dissection, although it's not called elective neck dissection in thyroid surgery. People prefer to call it prophylactic neck dissection. And it's really favored by those people that do feel that occult nodal disease has a negative effect on outcome, although this is not proven. People feel that occult nodal disease cannot be properly identified in the central compartment with either a CT or ultrasound scanning. There was a paper by one of our local colleagues, Professor Mark Siwak, who showed that thyroglobulin at 6 months was lower in those who'd undergone central neck dissection, although really it questions the relevance in a disease that lasts multiple decades. People feel that central neck can be performed safely, and some people feel that clearly reoperation in the thyroid bed is difficult and increases morbidity. However, those people who are generally against performing routine elective neck dissection would argue that micrometastases really have no outcome. There is no level 1 evidence that elective neck dissection has any disease-specific benefit. One of the things that I always question, if we believe that an incident of 50% is significant, why don't we dissect levels 4, 3, and 2? And I guess this is what the Japanese did in the original days. One can perform a CT scan, and this will tell you whether there is clinically relevant neck disease. I do believe, a number of people believe, that elective neck dissection does have higher morbidity, not necessarily in terms of the nerve, but certainly in terms of parathyroid function. And I'm certainly a strong believer that reoperation performed safely in expert hands can be performed with very low risk to the patient. And really, one should reserve elective neck dissection of the central compartment to high-risk patients only. And when you look at some of the literature, and this is a paper from 2018 that looked at a number of papers and again showed that there are significant higher risks of performing central neck dissection routinely, and the effect on rates of recurrence really remain uncertain. So when you look at the American guidelines, there are weak recommendations and low quality evidence to consider elective neck dissection, even in large tumors in older high-risk patients. And there are strong recommendations to not perform elective neck dissection in those very low-risk tumors. Upper area digestive tract invasion, I'm just going to make a quick comment. As I said, the incidence ranges between 1 to 20%, but I think in routine general practice, it is very much to the lower end. Most commonly, strap muscles are involved, but clearly other parts of the upper area digestive tract get invaded, particularly the recurrent laryngeal nerve. And one must not forget that it's not often just one structure that gets invaded, but a number of different structures get invaded together. There is clearly no doubt that this has a significant prognostic effect on the outcome and on the patient. And really the aims are foremost to macroscopically get rid of all the disease, ideally microscopically, but this is often quite challenging. And again, one needs to balance the risk versus the benefits and foremost preserve upper area digestive tract functions. I looked at patients with this some years ago with Jeremy Freeman, and we showed that people can live actually for quite a long time with the extrathyroidal spread. And therefore, we must really ensure that morbidity from the treatment is not worse than it is from the disease, and really need to consider quality of life. When we look at the risk of structural recurrence, there are a number of factors that we find after pathologic evaluation, and probably significant lymph node involvement, measuring more than 5 nodes involved, certainly clinical nodal disease, and anything more in terms of extrathyroidal spread, BRAF mutations, and vascular invasion really raise the risk of recurrence in excess of 20%. And generally, these people would all fare best with total thyroidectomy and adjuvant radioactive iodine. But one must not forget how patients respond to treatment. And this is, again, the concept I alluded to that Professor Tuttle has sort of let us know. And if patients have an excellent response to treatment, their chance of biochemical recurrence is actually quite low. If you have an incomplete response in terms of thyroglobulin and certainly ultrasound, then the risk of structural recurrence really goes up quite significantly. And this is something that we need to consider when we are allocating treatment. So overall, the vast majority of patients who present with well-differentiated thyroid cancer have an excellent outcome no matter what we do. We need to balance the risk versus the benefits of therapy and certainly consider conservative unilateral surgery in those low and intermediate risk patients. I think in today's personalized approach, you need to discuss and at least offer surveillance for incidental micropapillary thyroid carcinoma. There is no doubt that high-risk patients should be treated maximally with total thyroidectomy, consider central neck dissection and radioactive iodine. There is no doubt that clinical nodes need to be removed, and I feel there is no role for elective, certainly lateral neck dissection. High-risk patients require multimodality therapy, and low-risk patients we can de-intensify. The best approach is achieved with a team approach. We cannot do this in isolation. We need to have a sound understanding of disease processes and practice a personalized approach. I think it is important that anybody that embarks on this surgery has an adequate caseload, adequate training, and participates in continued medical education, audit, and research. Thank you very much.
Thank you, Dr. Carsten Palme, for a elusive talk. So we have a number of questions lined for you. So we will start with the first one. That's from Dr. Yusu. In low-risk, well-differentiated thyroid cancer patients, what type of surgery is best?
It really depends on, if you have an isolated small node, there's not much happening, a small isolated nodule on one side, there's not much happening on the other side. You are dealing with a young patient, a female patient. The needle biopsy suggests a papillary thyroid carcinoma. There is no obvious nodal disease seen on clinical examination or on your ultrasound. I think there is no doubt that in my hands, I would generally offer the patient a unilateral surgical approach, starting off.
Okay. The second question is from Dr. Satyabrat Fukan from Guwahati. Tumor factor or patient factor, which is more important in an intermediate risk patient?
I think it's patient factor. If I have a patient that's male, that's older, and a patient who has a family history, a patient that has a history of ionizing radiation, I would be a lot more concerned, and I would be certainly leaning to a more aggressive and complete operation.
Okay, so question is from Dr. Mayuri Rajpurkar. She wants to know whether you would like to know the physician or institutional factors for choosing against active surveillance or lobectomy.
It's a good question. I think if you're going to have active surveillance, you're going to have a number of things. You've got to have a patient that is happy to live with a cancer. You're going to have a patient who is going to turn up regularly. You're going to have a patient that will be aware of themselves and report any new changes to you promptly. And you're clearly going to have your endocrinologist and your radiologist on board. And you need to have a consistent radiologist. That is, the ultrasound needs to be done by the same department or the same person on a regular basis.
Okay, sir. So if you choose to happen active surveillance, what are the patient or physician factors that make you change your approach down the line?
Well, I think, what physician factors you think?
Yeah, physician or patient factors.
Yeah. Well, the patient factors would be if the patient can't follow up, if they're from a long way away. Certainly if they're uncomfortable with the concept of leaving a cancer in situ. And then if you have a team or an institution that is unwilling to participate. As I said, you know, I think there are a number of opinions in treating anything we do, and we need to have a consensus. You know, we need to have a team approach. This is, you know, we don't treat these in isolation, we treat them together. And if there are any concerns by anybody else, and certainly my endocrinologist, then I'm going to listen to those, and we're going to come to a consensus to make sure that we're on the same page. Because one of the worst things for a patient is to have an inconsistent messaging and a team that is not on the same page. Because as we know, thyroid cancer is bloody hard enough. You know, there are so many ways of treating it without confusing the patient by a team that's not on the same page.
Okay. So we have another question. Do we need to take a relook at papillary thyroid microcarcinoma with size less than 1 centimeter? And do we need a relook at papillary thyroid microcarcinoma in those with less than 0.5 centimeter, especially in some cases of high risk types like hobnail variant?
Yeah, look, I think the reality is that there are always going to be outliers. There are always going to be patients that, and if you look at the data from the Japanese, you know, there are people that progress. There are people that will develop distant, or, you know, distant, rarely, more local regional recurrent, you know, disease progression. But it's very difficult to predict those patients based on other factors. But fortunately, the numbers are low. And if you look at if you look at anatomic studies and autopsy studies, you know, the numbers are pretty high in the world. You know, if we have a world population of 6 billion, right, there are 600 million to 2 billion people who walk around with micropapillary carcinoma. And they all get to the age of 110, right? And I think this is the sort of thing that we need to share with the patient. And based on their comfort, you know, we need to allocate the appropriate personalized treatment. So again, I don't think one size fits all, but we need to have a sound understanding of the disease and share that honestly with the patient.
If another question, if central neck is positive, do we need to address the lateral neck as well?
Yeah, look, it depends on whether the central neck is positive in a micropapillary sense, in an incidental occult sense, or the central neck is positive, you know, macroscopically. There are large nodes, but if there was a clinically relevant node in the lateral neck, I would like to think your examination and your pre-surgical ultrasound would have picked that up. Now, Professor Greg Randolph will talk about the use of CT, and certainly he is a huge advocate in using CT scanning on patients with papillary thyroid cancer. I'm not an advocate as a routine, because I think the vast majority of people don't have clinically relevant disease. That doesn't mean they don't have microscopic disease, right? But the question is, what's the relevance? And you need to, again, balance the risk versus the benefit.
Okay, sir. Sir, another question from Dr. Devendra Chokar, sir. He wants to know, would you perform a total thyroidectomy for a lateral neck node less than 3 centimeter for a 1.5 centimeter thyroid nodule?
Look, the reality is, if you've got a lateral neck node, right, that's clinically relevant, you know, you are, and depending on the patient factors, you know, if you're an older patient, that is significantly going to impact on your prognosis. So the treatment needs to be upskilled, right? In terms of a young patient, they'll be at risk of recurrence, not necessarily a reduction in outcome, but in recurrence. So the thing about treating them with total thyroidectomy up front is just to reduce or improve their disease-free interval and reduce their morbidity from recurrence in the future. So I would probably, with patients with clinically relevant disease, do a total thyroidectomy.
Okay. So again, a question from Dr. Yusu. What is the most common complication in thyroid cancer surgery in your surgical practices?
The most common complication
in your surgical practice.
I don't have any complications. Look, there's no doubt that hypoparathyroidism is something that happens more than we like to admit. Fortunately, I think most of them are transient. So my permanent hyperparathyroidism rate, and I think one of my endocrinology colleagues is online, so he can tell you whether I'm lying or not, but you know, is very low. It would be less than 1% or less than 0.5%. I think a weakness of the recurrent laryngeal nerve, at least temporary weakness, is a lot more common than we think, and we just don't look hard enough, right? And I think that the routine use of nerve stimulation has really focused our attention. And I've certainly been using nerve stimulation for over 20 years. So although my loss of signal and my temporary rate is way less than 5%, it's still a lot higher than sometimes I like to think. And when you look at the parotid literature, right, if you look at facial nerve dissection, if you're honest, a facial weakness temporary occurs in up to 30% of cases. Now, in the facial nerve, you know, because you look at them, they're a bit asymmetric. But often, unless you practice nerve monitoring and routine looking at the patient with nasendoscope, you're not going to pick up the little transient nerve paresis, you know, that occur in the first month or so.
Because of constraint of time, we'll take the last question, which is how often is follow-up recommended if patient opts for active surveillance?
Look, that's a great question. And I have to be honest that although in our institution or in our country, we certainly offer it as a matter of routine, you know, very few patients take us up on it. So to be quite honest, I don't practice active surveillance as a routine. I do have some patients who actually have nerve palsies from idiopathic causes on the contralateral side to a cancer on the only functioning side, and those patients have actually elected to be watched. You know, and these are tumors that are 10 to 15 millimeters, and I've done ultrasounds on them every 6 months. But it's really important to do it at the same place and make sure you evaluate the 3 dimensions as best as possible in order to get a volume estimation, because you might find that even though certain parameters don't change, some do, and the volume is actually a lot higher than you think.
Okay. Thank you so much, sir, for your time. And now we will